Hi everyone. Hopefully you can hear me fine. I'm just going to introduce the latest webinar today. It's 4 o'clock in the UK, so we can get going. Just some admin before we start. Obviously, everyone's muted, why we can't hear everyone. But please do participate in the webinar. There's a chat at the top that you can ask any questions, and basically how it's going to run is that Amita is going to give her presentation, and we'll have time at the end to go through any questions. So you can either use that chat, or there's the raise the hand feature as well that we can use. Just to also mention that the session's recorded today, and we will be putting this up on YouTube shortly after this presentation. If you just go to the next slide, Amita. Yeah. So this is our presenter today, Amita. She's been at Simcyp about 5 years now. She's a senior research scientist, and primarily, and a lot of her work in Simcyp has been focusing on development and expansion of the pediatric, as well as the pregnancy and lactation modules. And today, obviously, the focus of her talk is going to be talking about these recent advances and also case studies. So the application of these models in an important special population, which is pregnancy. And I'll leave it to Amita to go over all these topics that she's going to be covering in her presentation. But thank you, Amita, for agreeing to speak to us today, and looking forward to your presentation.
Thanks, Oli. Thanks for the nice introduction. And hello, everyone. So as Oli said, I'll be outlining my presentation in terms of explaining the case study and talking more about the PPK modeling side on the pregnancy, lactation, and also showing some case study on the perinatal PPK model application utilizing this both model and other model in Simcyp. So let's start with the status looking into the pharmacotherapy during the pregnancy or the lactation. So I'm sure many of you yourself, or maybe have someone seen someone around you, when they have to take medicine during the pregnancy, they wonder whether the drug that they are taking that might affect their baby or not, or whether it's safe for the fetus or not. While in many cases it might be for a minor condition, but in many cases it might not be minor and needed a certain medication to treat certain condition, which might be the pregnancy related, breastfeeding related, or could also be some chronic condition the mother is facing for long and taking the medicine for the same. One such case I came across was a fairly recent case study. It was from one of the USA hospital setting where the doctor were dealing with the dilemma whether to treat or not to treat. So there was a woman in the end of her pregnancy, and she experienced a very high blood pressure. And the doctors couldn't treat the condition due to the plenty of drugs that were available for the hypertension were not approved for the use in the pregnancy. And the dilemma was that if it is not treated, it might induce the preeclampsia in those women, which can be harmful to the fetus or as well as to the mother. So there are certain conditions where the drug treatment is not avoidable, and it's important to know how it might affect to the fetus or to the maternal. So let's look into the status, what data suggest, what we have in the literature. From one of the review article which was recently published, says that most women take
questions.
one or more
So
medication
you
during
can
the
either use
pregnancy
that
and
chat, or
lactation.
there's the
And the
raise a hand
statistics suggest
feature
that
as well
around
that we can
60% of the pregnant women take
use.
either one or more
And just to
prescription
also
drugs
mention
for
that the
their either
session's
pre-existing
recorded
condition
today,
or they related to the pregnancy
and
conditions.
we
And
will
around
be putting this up on
percent of the
YouTube
women who are breastfeeding
shortly
take
after
some
this
amount of
presentation.
drug or their supplement during the lactation.
You just go to the next
While
slide, Amita. Yeah.
we look into the
So
data availability,
this is
the data
our
suggests that
presenter
around
today.
90% of the clinically
Amita,
approved
she's been
medication, they do not have the
Simcyp for about
appropriate
5 years
drug
now.
labeling
She's a
information
senior research
for the use in
scientist,
the pregnant or lactating women.
and
While the
and a lot of
care
our work
professional rely on the
in
availability
Simcyp
of the
has been
information
focusing on
to provide or
development and
prescribe the drug,
expansion of the
let's look into
pediatric
the
as well as the
information
pregnancy
what
and
is available
lactation
in the drug label.
modules.
So this is one of the review
today,
article
obviously,
evaluating
the
the
focus
drug
of her
label from the
talk is
last
going to
10
be
years.
talking about
And looking
these
into
recent
the
advances
result,
and
it
also
suggested
case
that
studies.
the total of
So the
290
application of
drug
these
levels
models
that they looked into,
in
they
an
could only
important
found the
special
data
population, which
for
is
the
pregnancy.
pregnancy in human for 8
and
labels, and
I'll
for
leave it
lactation
to
only the 31
Amita to
drug
go
labels
over
have data on the
all
human.
these
So you can see the
topics that
number
she's
of
going to be covering in her
information available
presentation.
is very
But
less
thank you,
percentage
Amita, for agreeing
in terms
to
of looking
speak to us
into the
today, and
information
looking
that is
forward to your
available in the drug
presentation.
labels. As I said,
Thanks,
it
Oli.
might
Thanks
not
for
be
the nice
avoidable in
introduction,
some
and
cases.
hello,
It's
everyone.
important to know
So as Oli
what would be the proper
said,
dosing
I'll be
to
outlining my
prevent the
presentation in
poor
terms of
disease control
explaining
and to treat
the case study and
the maternal,
talking more about
as well
the
as looking
PPK
into the
modeling side
fetal
of the
outcome,
pregnancy,
that it should not
lactation,
be
and also showing some case study on the
to the
perinatal PPK
fetus.
model
And we
application
know the
utilizing this
well-known
code
case
model
of
and
thalidomide
other
as well.
model in Simcyp.
So it's really important to
So
have
let's
the
start
medicine
with
for
the
the well-being of the
status
mothers
looking
as
into
well.
the pharmacotherapy
While
during
we
the
know there
pregnancy
are
or
challenges
the
in
lactation.
so I'm sure many
Doing
of
the clinical
you
trial
yourself,
in this
or maybe have
population, whether it's
someone
pregnancy or
seen someone
the
around you
lactating
when they
mothers,
have to take medicine
although
during the
the
pregnancy,
things
might be
they wonder
changing,
whether the
but
drug that
there
they
are
are
still
taking that
some
might affect
challenges
their baby or not, or
in
whether
doing
it's
these
safe
clinical trials
for the fetus or not.
in a wider scale.
While in many cases
That's where maybe the
it might be
PPK model
for a
can play
minor
an important
condition,
role,
but in
and
many cases
we'll have a
might
look
not
into
be
how
what we have and what can be done
might not be
with the
minor
PPK
and
model with
needed
the
a
case
certain
studies.
medication to treat certain also, condition, there are different
which
regulatory
might be the
authorities
pregnancy related, breastfeeding
provided,
related,
or could also be some chronic
regulatory
condition
aspects and
the
guidelines
mother is
facing for
and they
long
also
and taking
suggest
the
the
medicine
potential
for the same.
utility of the PPK model.
One such case I came across
as provided here in
was
the
a fairly
different
recent case study.
documents
It was
given
from
by the different
one of the
regulatory
USA
authorities.
hospital
So this
settings,
is for your reference
where the
to
doctor were dealing with the
follow.
dilemma whether to treat or
Okay,
not
so
to
let's
treat.
start with the pregnancy.
So there was a
side of
woman
things,
in the end of her
looking into the
pregnancy, and she
Simcyp
experienced a
model,
very
the
high blood
platform
pressure,
includes the maternal model,
and the
to look
doctors
into the
couldn't
pregnancy-related change in the
treat
maternal
the
exposure,
condition due
or
to
we also
the
have
plenty
a
of
full
drug that were
feto-maternal model defining
available
all
for
the
the maternal
hypertension
and
were
as well
not
as the
approved
fetal
for the
organs
use
in the pregnancy.
So here
And the dilemma was that if it is not
physiologies are
treated, it
defined in
might
the model
induce
with the continuous growth function,
preeclampsia in
and
those
also
women,
provides the
which can be harmful
user-friendly
to the fetus
interface,
or as well
which
as to the
provides the
mother.
additional
There are
flexibility for
certain
users.
conditions where the
Here for the
drug
full
treatment is
feto-placental
not
model,
avoidable,
we have
and it's important
three
to
compartment
know
placenta
how
model
it might affect
connected
to
to
the fetus
the
or to
fetal
the
model,
maternal.
which
So let's
allows
look
the
into
prediction
the
of
status,
the maternal,
umbilical, what data suggests, what
and
we
all
have
the fetal organs
in the literature,
as they are all defined
from
in this full
one of the review
feto-maternal
article
which
organ was recently
as well as you
published,
can
says
also
that
see
most
the
women
drug
take
concentration
one or
in the
more
placental
medication
tissue
during the
and
pregnancy and
amniotic
lactation,
fluid,
as well as they
and
are
the
also
statistics
defined in the
suggest that
model.
around 60% of
The information for
the
one or
modeling
more
and the data
prescription drugs
consideration were
for their
provided
either
earlier in the
pre-existing
literature,
condition or they related to the pregnancy conditions. And
while
around
we know as the
70%
pregnancy
of the women
progresses,
who are
there are many
breastfeeding
changes in the
take some amount
physiological
of
parameter, drug or their
affecting the
supplement
overall
during the
drug
lactation.
disposition throughout the
While
gestational. So these parameters, there are different parameters. The data suggests that around 90% of the clinically approved medication, they do not have the
integrated
appropriate
within the
drug
model
labeling
as a function of
gestational
for
age
the use in the
the
pregnant
most
or
important,
lactating
as you can
women.
see here on the maternal
While
side,
the
is the activity of the
care
different Simcyp
professional
and UHT
rely on the
enzymes
availability of the
information
that might affect the
to
overall
provide
drug
or prescribe the
disposition.
drug.
So based
Let's
on the
look
data
into
availability, we have
the
provided the
information what
ontogeny
is
for the
available in
different
the
Simcyp
drug
enzyme.
enzyme. As you can
So
see,
this is one of the review
1A2 to
article
D6, 3A4
evaluating
recently
the drug level from the last 10 years as well.
And looking
you can
into
see the changes in
the result, it suggested that the total of 290 drug levels that they looked into, they could only found where the data was available.
Data for the
So we recently added the for 8 labels, and for lactation only the 31 drug labels have changes in these so you can see the number of information available. Similarly, the changes in the fetal physiological parameters is also included in the model available in the drug labels. As I said, it might not be avoidable,
and these
in
are
some
integrated
cases.
within
It's
the model
important to
and taken
know
into
what would
account
be the
with
proper
fetal
dosing
model to prevent the
while there are
poor
more
disease
research
control
going
and to
on
treat
for the placental
the
transporter,
maternal
the placenta
as well as
model
looking
also
into the
allows
fetal
you to
outcome
incorporate
that
the
it should not
transporter
be
kinetics with this
teratogenic to the
fetal-placenta
fetus.
permeability
And
limited
we
model.
know the well-known case of
So
thalidomide
you can
as
see
well.
the 3 compartment
So it's
model
really
defined
important to
here.
have the medicine for
So the
the well-being
transplacental
of the
transfer can
mothers
be
as well.
assigned here,
While we
utilizing
know
either
either
the
the ex vivo
challenges
placental
in
perfusion experiment or the
doing
in
the
vitro
clinical
data or
trial
the
in this
FISCAM data with the
population, that is
prediction tool
pregnancy
provided
or
within
the
lactating
Simcyp.
mothers. Although
While
the
all the
things
tissue,
might be changing,
fetal tissues are
but
defined,
there
it
are
is also
still
important
some
to take into
challenges
account the
in
different
doing these
fluid
clinical
transfer within the
trials
uterus
in
to
a wider
accurately
scale.
predict the drug concentration
That's
in the
where
fetal
maybe the PPK
circulation
model
or
can play an important
the
role, and
amniotic fluid.
we'll have
As
a
you
look
can see,
into
there
how
are different
what
fetal
we have and
elimination
what
pathway
can
like
be
fetal
done with
swallowing
the
and
PPK model
fetal
with the case studies. Urine
also,
excretion
there are
that might
different
affect your drug
regulatory
concentration
authorities
around the
have
fetus and the
provided
amniotic fluid.
so these all
Some
these
regulatory aspects
parameters,
and
these
guidelines,
fetal-placental elimination
and they
parameters
also
are also
suggest the
defined within the
potential
model to
utility
allow
of
the
the accurate
PPK
prediction
model
of drug in the
as
amniotic fluid
provided
and
here in
fetus
the
as well.
different
Documents
so
given by the different
looking into
regulatory
the
authorities.
different
So
model
this is for your
capabilities
reference
and the case studies, this is one of
follow.
the example.
Okay, so let's start with the
showing the
pregnancy side of
feto-maternal
things.
PPK modeling
Looking
approach
into the
coupled
pregnancy
with the Simcyp
model,
model,
which
the
represent the
platform
maternal
includes the
kidney
maternal model
with a detailed
look into the
mechanistic model,
pregnancy-related
which allows
change
you
in
the
the
maternal
inclusion
exposure,
of
renal
or we
transporter
also have
kinetics,
a full feto-maternal model
and with this
defining all the
inclusion
maternal
as
also
well as the fetal organs.
inclusion
So
of the
here, all the
gestational
dependent
maternal
changes in the
physiology
activity
of
are
the
defined in the
transporter
model with the continuous
for the
growth
maternal and
function,
fetal
and also
prediction
provides
where
the
the
utilized here. As you can
user-friendly
see, the
interface
PPK
which
model
provides
inputs
the
provided here.
additional flexibility for users.
We have taken into
Here for the full
consideration the
feto-placental
transporter
model, we
ontogeny, which
have
is already available in the
3
simulator.
compartment placenta model
For the
connected
different
to
drugs,
the
as you
fetal
can see,
model,
it was
which allows
done
the prediction
performed
of
for the
the
different drugs
maternal umbilical
in two separate
and all the fetal organs
publications,
as
and
they are
we
all
taken into
defined in
account
this full
this similar
feto-maternal
organ
workflow or the
as well
approach
as you can also
for
see the
parameterizing
drug
the model.
concentration in the placental
For the
tissue
defining
and
the
the amniotic fluid,
transplacental
as well as they are also
we
defined in the model.
included
The information
different
for
approach
the
to provide
modeling
it
and
and the
also
data
utilizing the
consideration
prediction
provided
tool that we
earlier.
have in the literature.
The fetal renal clearance and other fetal elimination
While we
pathways
know
were
as
also
the pregnancy
defined here
progresses,
to
there are
predict
many
the
changes in the
concentration in the
physiological
fetus as well.
parameter. We also
Affecting
have
the
a unique
overall drug
functionality
disposition
taken
throughout
into
the
account
gestational.
the time
So
varying
these
physiology,
parameters, there are
so that
different
were also
parameters
applied
that
for the
are
long simulation to allow the
considered,
continuous update of the
analyzed,
model while
and
the simulation is
integrated
running
within
for
the
the long
model as a
time, and
function
also
of
updating
gestational
the
age.
gestational
The most
related
important,
parameter
as you can
with
see here
time.
on the maternal side, is the
So
activity of the different CYP and
these
UGT
were
enzymes. This approach
that
was
might affect
followed
the overall
for
drug
the several
disposition. So
renal
based on the
eliminated
data
drug
as I
availability, we have
mentioned,
provided the
without
ontogeny
fitting
for the
or
different CYP
adjusting
enzyme,
any of
as
the
you can see for
physiological parameter
CYP1A2
or the
to
compound related
D6, D6,
parameter here.
recently CYP2A1 and UGT1A1
Looking
as
into
well.
some of the
And you can see the
performance
changes in
from
the
the same
enzyme
approach that I mentioned
with the
with the
gestational
feto-maternal
MACI model.
also,
This
we
shows
have
the
also
performance for the
provided the ontogeny
metformin.
for some of the
As you can
transporter
see,
where the data was available.
model performance
So we
was done
recently added the renal
considering
OCT2
the best
practice
practice
approach to
renal
first
OT3
verify the
as
model
well,
in
and
the
you can see
non-pregnant
the changes
women,
in this
and then taking into
activity of
account the
transporter as well.
pregnancy-related changes and
Similarly, the changes
predicting the
in
drug
the
concentration
fetal
in the
physiological parameters
different
is also
gestational
included in the
weeks for
model
the
to
pregnant
define
women.
all
As
the
you can see
fetus
at the different gestational week,
tissue.
the
And these
model
are
could
integrated
perform
within the
well
model and
with the
taken into
observed
account with the
concentration
fetal
provided
model.
here. Also, the model
While there
performance
are
was
more
done
research going
to
on
see the
for the
drug
placental
concentration during
transporter,
delivery. So you
the
can
placenta
also
model also
see the
allows you to
performance
incorporate the
here during the
transporter
delivery.
kinetics. with this feto-placenta permeability limited model.
Report that suggests there is an
so you can see the
renal
clearance, which can also be seen from
So
here
the transplacental
during the
transfer
pregnancy,
can
which
be
has a
assigned here
significant effect on the
utilizing
overall
either
maternal
the
exposure,
ex vivo placental
while
perfusion
it is
experiment or the in
OCT2
vitro data or
substrate,
other physcam
and we
data
know
that
that
we
the
have an
prediction tool
ontogeny
provided
within the Simcyp.
provided or included in
While
the
all the
simulation.
fetal tissues are defined,
You
it is
can look
also
into
important to take into
the
account
simulator
the
to
different
see
fluid
the
transfer
contribution
within the
of the
uterus
to
to
the renal
accurately
clearance
predict
for
the drug
these different
concentration in the
pathways.
fetal
So you
circulation
can see
for the
for
non-pregnant
the
and
amniotic fluid.
pregnant women.
As
With
you can see,
20
there are
gestational week and
different
40
fetal
gestational
elimination
week,
pathway, like
how
fetal
the
swallowing
contribution
and
of the different pathway
urine excretion
contributing to the
that
total
might
renal
affect your drug
clearance, like
concentration around the
GFR,
fetus and
OCT2
the amniotic
uptake.
fluid.
And
So
here
these
you
can clearly see for the non-pregnant label, the
are also defined within
contribution
the model
of
to
the
allow the
OCT2
accurate
pathways
prediction of
90% was increased to
amniotic fluid
around
and fetus as well.
29% at around term due
So,
to the increase in
looking
the
into
activity
the
of these enzymes,
different model
these
capabilities
transporters.
and the case studies, this is one of the
Also,
example
showing the
with
feto-maternal PPK modeling approach
coupled with the McKim model, which represent the maternal kidney
based on the
with a detailed
available
mechanistic
data,
model,
as you can see
which
here.
allows you
During the delivery,
inclusion
the
of
concentration
renal
in the
transporter
umbilical vein is
kinetics.
provided here.
And
we
with
also
this
looked into
inclusion,
the different
also
literature providing the
inclusion of the
umbilical vein
gestational dependent
concentration. And here
changes
we
in
are
the
looking
activity of
into
the
the
transporter
5th and 95th percentile
for the
different
maternal and fetal
doses in these
prediction were
different
utilized
color,
here. As you can see,
dashed
the
bars
PPK model inputs
and
provided here.
this color dashed lines, and these
We have
bars
taken into
provide
consideration the
observed
transporter ontogeny, which
concentration
is
with
already
the
available
mean
in
and
the
range
simulator.
provided from the different literature. And
For
overall,
the
you can
different
see
drugs, as you can see,
by including
it
the
was
ontogeny
done
and the
performed for the different drugs
with the mechanistic kidney model,
two
we
separate
could see the model
publications,
performance for
and
the
we taken
metformin.
into account this similar workflow
Similarly,
or the approach
some other example
parameterizing
showing
the
here
model.
for the amoxicillin,
For the
where
defining
there
the
is an involvement of
permeability,
OAT3 transporter, and you can also see by just the
providing
approach to provide it, and also
OAT3
utilizing the
transporter
prediction
ontogeny,
tool
we could
that we
also
have.
predict
The
fetal
amoxicillin
renal clearance and other fetal
at different
elimination
gestational
pathways were
week,
also
for
defined
the
here
different
to
dosing
predict the
regimen,
concentration
whether
in the
the
fetus as
intravenous
well.
or the oral. And you can
We
also
also have
see
a
the
unique functionality
performance that
taking
the
into account
model
the
would predict
time varying
the
physiology,
concentration
so that
for
were
this
also
amoxicillin
applied for the long
at different
simulation to
gestational
allow
week
the
as well.
continuous update of the model
while the simulation is running for the long time, and also updating
Similarly,
the
for the
gestational related
ciprofloxacin exposure
parameter
at term,
with time.
it was also predicted well.
So
And you can
see the
these were
prediction in the maternal
this
plasma and
approach was
umbilical
followed
vein.
for the several
But there were also
renal
the data
eliminated drug,
available, as I
for the
mentioned,
different fetal
without
tissues,
fitting
which
or
model could
adjusting
also
any of the
predict
physiological
and
parameter
was
or the
also
compound related
matched with the
parameter here.
clinical
Observation provided in
looking
these
into this,
fetal
some of
tissues,
the
as you can
performance
see for the
from
fetal
the same
kidney,
approach
lungs,
that I
heart,
mentioned with
and
the
also in the
feto-maternal
fetus
McKim model.
in the amniotic
This shows
fluid
the
as well.
performance for the metformin. As you can see, model
Okay, so
model performance
this is another
was done
example
for the
considering the
feto-maternal
best
McKim
practice
model
approach to first
where
verify
you can
the
see,
model in the non-pregnant
the prediction
women,
can be
and then taking into
extended
account
to
the
all the
pregnancy
tissues, and
related
the
changes
predictions
and
are given here.
predicting
While
the
the
drug
data were not
concentration
available
in
for
the
most of the
different
tissues,
gestational
the
weeks
least
for the
detectable
pregnant women, as you
concentrations
can
were
see
provided
at the
without
different
providing any
gestational week.
specific time point.
The
So
model
these are
could
just
plotted
perform
as
well
a
with the
as a red
observed
line
concentration
here,
provided
showing
here.
that
Also,
what
the
was
model
the
performance
least
was done
detectable
to
concentration in
see
the
clinical
drug
scenario.
concentration during delivery. So you can also
Okay, so
see the performance
there
here
are also
during the
some
delivery.
external publication utilizing the Simcyp feto-maternal model.
This is one of the example for the
renal
drug clearance, which can also be
where they
seen
try to
from
predict
here
during the
where they
pregnancy, which
utilize
has
a
a significant
significant
to predict the
effect on the overall maternal
fetal
exposure.
While it is
So they also
OCT2
did some
substrate,
human
and
placental
we know that
perfusion
we have an
experiment and
ontogeny
provided or
the
included
information
in the
model.
simulation.
So this is
You can look into the simulator to see
and
the
it's currently not
contribution of
recommended in the
to the renal clearance for
living
women with
different
HIV,
pathways.
because
So you
there's
can
no
see for the
efficacy or safety
non-pregnant
data
and
available
pregnant
here.
women with
So
20
they
gestational
look
week and
into
40
the
gestational week,
overall
how the
exposure in the
contribution
maternal and
of the
fetal
different
side
pathway,
contributing
can
to
see
the
here,
total renal clearance, like
they looked into
GFR,
the
OCT2 uptake.
maternal exposure
And here
for
you can
the non-pregnant
clearly
women
see
for the
first and then
non-pregnant label
extended it to the pregnant women, looking
contribution
at
of the
drug
OCT to
exposure
purchase
at
was
different
19% was
gestational weeks,
increased
and
to
also
around
the in vivo
29%
target is provided
at
here.
around term.
So they did
Due
it
to
for
the increase
a
in the
single dose
activity of these
regimen
enzymes,
and
the
the BID dose regimen, and with that they provided that
as well
for
with
the
the
single dose
maternal, we have
regimen, you
also
see there
the C-trough
predicted the concentration in the umbilical cord
target, so that
based
it
on
might
the
not be
available data, as
that
you can see
efficacious,
here.
and BID
During the
dosing
delivery,
might
the
be a
concentration
better
in the
option
umbilical
here.
vein is provided
When they
here.
also looked into
And we also looked
fetal,
into the different
overall
literature
fetal exposure
providing
as well,
the
and the
umbilical
in vivo
vein
target is
concentration.
plotted here.
And here you are looking
And
into
they saw the
5th and
considerable
95th
fetal
percentile for the
vein
different
exposure,
doses in these
prediction
different
here,
color
which highlighted
dashed
the
bars.
need to
And
look into the
this color dashed
safety
lines
of
and
these
these
bars
exposure
provide
in the
the
fetus.
observed
So
concentration with
they
the mean
utilized
and
the
range
model
provided from the
to
different
look
literature.
into
And
the
overall, you
different
can see
scenario for
by
the
including
different
the
dosing regimen
opportunity
and
how
the
the prediction will be,
with the
and
mechanistic kidney
how
model
it
we could see
how it will
model
be
performance
efficacious
for the
to
metformin in the maternal, and looked into the different case
Similarly, some
studies
other
here.
example
Another
showing here for the
example
amoxicillin, where
for the
there is an
indomethacin
involvement
where
of
they also
OAT3
utilize the
transporter,
Feto-maternal
and you can
model
also see by
to
just
look into the
providing
different
OAT3
drug
transporter
exposure at
onto
different
you could also
trimester.
predict the
Similarly, they followed the
amoxicillin
best practice
concentration at different
first deriving
gestational
the
week
model for
for the
non-pregnancy, and
different
then with the pregnant
dosing
women
regimen,
looking into the
whether the
different
intravenous or the oral.
trimester, and you can also see the
Trimester
performance
data,
that the
and
model
also
could
looking
predict
into
the
concentration
concentration
for this
for
placental
amoxicillin
or the fetal
at different
circulation as well.
well.
So the drug was a mix of
Similarly,
different for the ciprofloxacin
enzyme
exposure at term,
involved for
it
this
was
elimination.
also predicted well.
They tried
and
to
you can
find
see
out
the
with this
prediction in the maternal plasma and the umbilical vein,
that
but there
to
were
see
also
the
effect
data
of
available
pregnancy-induced
for
changes
the
on their
different
fetal
parameters.
tissues.
So what
which
they did
model
is that
could
they
also predict and
was
perform the
also
sensitivity analysis
matched
over
with the
different
clinical observation
provided
different
in
these
parameters that
tissues,
were
as you can see
included
for the fetal
in the
kidney,
pregnancy
lungs,
to see
heart,
which parameter
and also in the
is most
fetus
affecting
in the
overall
amniotic fluid
changes
as
in
well.
the pregnancy. And as you can see here, simply for the clearance,
Okay,
they
so
found that
this is another example
the UGT
for
changes
the
during the
Feto-maternal
pregnancy
model,
or the protein
where you
binding
can see
overall
that
affecting
the
more
prediction
to
can
the
be
changes in the
extended to
concentration
all the
in
tissues,
changes
and
in the clearance
predictions are
in
given
the
here.
different
While the data
trimester
were
in the
not available for
pregnancy.
most of the
So
tissues,
these type of
the
scenario can also
least
be
detectable
performed within the
concentration were
simulator
provided
to give
without
you
providing
more
any
information
specific
regarding
time
the
points. So
different
these are just plotted
aspect
of the
as a red line here
the drug
showing
disposition.
that what was the least detectable concentration in the clinical
While
scenario.
we have the model
Okay,
based on
so
the Caucasian population,
there are
the
also some
model
external
flexibility also
publication
allows you
utilizing
to
the
incorporate
Simcyp
the different
Feto-maternal model,
ethnicity,
and
and
this is one of the
see the
example
prediction in the
for
different
the
drug
ethnic
durability,
population, like here
where
for
they try to
example,
predict the
showing a
where
case
they
study
utilize Simcyp
for the
model to
prediction
predict
of
the
the
maternal and
ceftazidime
fetal
in
durability
Japanese
in
pregnant
exposure.
population.
So
Here,
they also did
so
some
first the
human
drug was
placental
the
perfusion
first the model was
experiment and
developed for the
provided
ceftazidime in the Caucasian
the
population
information
from
in the model.
non-pregnant, and the
So
prediction
this is
performed in the pregnant women.
this is
As
the
you can
drug
see,
which
the
is
prediction performance here
3A4
in
substrate,
the
and it's
Caucasian
currently
pregnant
not
women.
recommended in
The model was then
women
extended
living
to
with the
provide
HIV, because there's no
the
efficacy or
baseline
safety data
baseline
available
changes between the
So they
Caucasian and
looked
Japanese were
into the
incorporated into the baseline
overall
pregnancy
exposure in the
population.
maternal and fetal
The
side.
changes into the pregnancy-related
As you
changes
can
were kept
see here,
same, but the baseline population
they
were
looked
kept
into
to the
the
Japanese
maternal exposure
population.
for the
So it
non-pregnant
included
women
the
first,
Japanese
and then extended
pregnant
it to the
population,
pregnant women,
and
looking at
the exposure
drug
was seen
exposure at different
in these
gestational week,
and also the in vivo
developed
target
Japanese
is
pregnant
provided here.
population. And you can
So they
see
did
the
it for
overall
a single dose
verification or the
regimen and
model
the
performance
and
here
the BID
in the
dose
Japanese
regimen.
pregnant
And
population based on
with
the
that,
different
they
data provided
that
here
for the single
from the
dose
group,
regimen,
and
you
it could
see
predict the
the
maternal
concentration as well as the umbilical
in vivo
concentration
target, so
here
that it
in
might
this
not
case.
be that efficacious, and
Okay, so that
BID
was
dosing
about
might be a better option here.
pregnancy model.
When
We
they
also
also
have
looked
the
into
lactation
the
model
fetal
in Simcyp, overall
and this is
fetal
how the
exposure
lactation
as well,
model
and the in vivo
approach
target
is
is
applied.
plotted here.
So
And they saw the
any
considerable
mother
exposure during the breastfeeding taking the medicine that might go to the
maybe look
fetus
into
via the
the
breastfeeding.
safety of
So
these
that
this
can be
exposure in the fetus.
counted for
So
utilizing
they
the
utilize
lactation
the
model. So the PBPK model is
to
linked
look
to
into
the different
lactation model
scenario
here,
where we have either
dosing
the
regimen and
utilizing
how
the
the
lactation
prediction would
model
be, and
algorithm
how
either as a
it
QSAR
show
or
how
probability
it
limited
will
model, which will
be
see
efficacious
next.
to the
The different drug parameter and the different milk parameters are also
already provided
another
here.
example
Utilizing this
for the
indomethacin,
where they also utilize the
feto-maternal
profile
model
in the milk
to look
and you
into
already
the
have in the
different
plasma, and from that you
drug
can also
exposure
see
at
the
different
cumulative amount
trimester.
of drug in the
Similarly,
milk.
they follow the best
So
practice.
overall, you can get
first
the
deriving
milk
the
to
model
plasma
for
ratio from the
non-pregnancy, and
lactation
then in the
model,
pregnant women,
and it will also provide you the
infant daily
trimester
dose
trimester
calculations.
data,
So you can get
and
the
also
relative
looking
infant
into
daily
the
dose or the absolute
concentration in
infant
the
daily
different
dose,
placental or
and
the
that
fetal
infant daily dose can
circulation as
further
well. So
applied
the
to
drug
the
was
neonatal
a mix
PBPK
of
model that we already
different
have in Simcyp, like the preterm or the
enzyme
pediatric
involved for its
PPK model
elimination.
to look
They
into
try
the
to
how
find
that
out
particular
with this
dose will
sensitivity analysis
show the
within the
exposure
Simcyp
in those
that
neonates.
so
To
looking
see
into
the
the
effect of
lactation
pregnancy-induced
model,
changes on their PK
there
parameters. So
are
what they
two
did is that
model options we have. One
performed
utilizing
the
the
sensitivity
analysis over
published
a different
QSAR model.
the one that we have is the default
Parameters that were
Fletcher-Atkinson-based
model, and
in
you
the
can
pregnancy
also
to see which
utilize
parameter
this model
is
for
most
the
affecting
substrate
and
and
as well
overall
as for the
changes in the
metabolite.
pregnancy.
While
And
the
as you can see
model
here, simply
flexibility
for
also
the clearance,
allows you to
they
account
found
for
that
the other mathematical
model,
the UGT
like the
changes
other
during the
published
log
pregnancy
transform
or
phase
the
distribution
protein
model
binding
or the mescaline
overall
model.
affecting
So that can
more
be
to the
utilized here
changes
as well.
in the concentration
Or
in
you can also
changes
take
in the
into
clearance
account
in the
the more
different
mechanistic
trimester in
model,
the
the
pregnancy.
permeability limited
So
model, and
these type
account
of
for
scenario
the
can also be
different
performed within the simulator
breast or
to
milk
give
barrier
you more information regarding the different aspect
involvement
of the,
and can account for the transporter
disposition.
kinetics around it. And in both cases, you will get the similar
While
milk
we
to
have
plasma
the
ratio
model
and the infant daily dose
based on the
calculation.
Caucasian
And these
population,
milk
the
parameters
model
are provided
flexibility also
within
allows
the
you
lactation
to
library, and it is
incorporate
being
the
utilized in
different
this model.
ethnicity and
See the prediction
okay,
in
so
the
looking
different
into the
ethnic population,
some
like
of
here,
the
for
model
example,
performance that
showing
we
a case
looked
study
into. So this
for
is
the prediction
with
of
the
the ceftazidime in
default
Japanese pregnant
Fletcher-Atkinson model that we
population
have in
here.
Simcyp.
So
we
first
looked
the drug
into
was
the model performance or
was
the
developed for the
milk exposure
ceftazidime in the
for the
Caucasian
different drugs.
population.
Here
From
we
non-pregnant
have
and the prediction
shown
performing
like
the
four
4
drugs,
drugs,
as you can see the
acetaminophen,
prediction
digoxin,
performance here
alprazolam, and
in the
caffeine.
Caucasian pregnant
And you can
women.
see the drug exposure
The model
in
was then
plasma
extended
and the
to
milk on the
provide
right-hand side for all these drugs.
the baseline
And we also
baseline
looked
changes
into
between
the
the Caucasian and Japanese
different
were incorporated
parameters
into the
provided for the
baseline
milk
pregnancy
and mainly the
population.
milk to plasma
The
ratio.
changes into
And
the
as you can see,
pregnancy-related changes were
given
kept
here,
same, but the baseline population
and the
were kept to
predicted
the
milk to
Japanese
plasma ratio
population.
the model could predict.
So it included
the
Japanese
provided
pregnant
the
population,
clinical
and
the exposure was
the
seen
lactation model
in these
here.
all the
profiles
developed
were
Japanese
also
pregnant population, and you can see the
predicted well.
overall verification or
So
the
that was
model
with
performance
the
here
Flischker
in the
model,
Japanese
and
pregnant
we also looked
population
into some
based
of
on
the
the different
compound
data provided here
from the group,
and it could predict
milk
the
exposure
maternal
utilizing the
concentration
log
as well as
transform
the
model.
umbilical
So
concentration.
here you can
here
see,
in
for
this case.
example, paroxetine,
Okay, so that was
venlafaxine,
about the
and fluoxetine,
pregnancy
looking
model.
into
We also
the
have the
plasma and the
lactation
milk
model in
exposure.
Simcyp.
And
Also
this is
looking
how the
into
lactation
the overall
model to plasma
approach is
ratio,
applied,
where we also took into account
any mother
the
during the
different
breastfeeding
phenotypes
taking the medicine
given
that might go
for
to
the clinical study. So
the
we
fetus via the
provided that
breastfeeding.
particular phenotype
So
for
that
the
can
different
be
study
or
the clinical data that provided here.
model.
And
So
overall
the PPK
model
is
predict
linked to
the milk
lactation
exposure
model
well
here,
with this
where
model
we
as
have
well,
either the
and also the
lactation
model
where
the
algorithm
either as a QSAR
close
or
to the
permeability
observed
limited
one.
model, which we'll see next.
Looking into the infant
different
daily
drug
dose or
parameter
the
and the
relative
different
infant daily dose, we also
milk
predicted
parameters are
already provided here.
the infant daily dose
Utilizing
quite
this,
well,
the
and
model
the
will
prediction
provide you
versus
the
observed ratio
concentration
within
profile in the milk,
1.6 to
and you
1.74
already
in
have
all
in the
these cases
plasma.
for the different
And
studies
from that you
we,
can also see the cumulative
that we
amount of
performed
drug
here.
in the milk. So overall, you can get the milk to plasma ratio
First,
from the lactation
we're
model,
looking into the
and it will also provide
change
you
in the
the
milk pH.
infant daily
But
dose
first, look into here
calculations
about the
so you can
performance
get
of
the
the
relative infant daily
fluoxetine.
dose or the
So
absolute
as I said,
infant
we
daily
also
dose,
have the option
and that
to
infant daily dose can
look
further
into the
be applied to the
exposure
neonatal
as well
PPK
in the
model
milk.
that we already
So this
have
is the
in
performance
Simcyp,
showing
like
the
preterm or
parent drug
pediatric
in the plasma,
PPK
which you
model
already see in the last
look
example.
into how
So we
that
have the
particular
metabolite
dose
exposure
will
as well
show the
in the
exposure
plasma
in those
and in the
neonates.
milk.
So looking into the lactation
when
model,
we talk about the relative
there
infant dose,
are two
it's important
model
to
options
take
we
into
have.
account
One
also the
utilizing
metabolite
the
infant dose
published
as well,
QSAR
when we are
model.
looking into
The one that we
predicting
have is the
how much the
default
drug
Frischker
will be
Atkinson
ingested by
model,
the
and you
infant.
can also
So here we also
utilize
look
this
into the
model
different
for the substrate
relative
and as well
infant
as for the
dose,
metabolite.
as you can see for the
While
parent
the
and the
model
metabolite,
flexibility also
and
allows you
the
to
overall
account for the other
mathematical
parent
model
and
like the
metabolite
other
dose
published log
combined,
transform
the
phase
total
distribution
relative
model
or
or
the
the
Meskin
Meskin
model
model
so that can be
predicted closely
utilized
to
here
what
as well.
was observed
Or you
clinically.
can also take into account the more mechanistic
Looking into
model,
the
the permeability
sensitivity
limited
to
model,
the
and
milk
account
pH,
for the
we took this
different
example and are also looked
breast or
into
milk
the
barrier sensitivity
transporter
to the milk pH to see
involvement
whether
and
changes
can
in the
account for
milk
the
pH,
transporter
because there are
kinetics
changes in
around
the
it.
milk pH.
And in both
Happening
cases, you will get the similar
dynamically
from
from
the
the colostrum,
plasma
which is the
ratio and
early
the
milk,
infant
to
daily
the
dose
mature milk.
calculation.
So you
And
see
the
changes in the milk pH that might also affect the overall milk to plasma ratio.
utilized in this
So
model.
utilizing the sensitivity analysis
Okay, so looking
option
into
in the
we try to
some
look
of
into
the
the
model
sensitivity
performance
to the milk
that
pH,
we
as you
looked
can see
into.
here.
So this is with the considering the
Default
different
Frischker
milk pH
Atkinson and Bake
from
model that
milk
we
pH
have in
Simcyp.
to
So we
8,
looked
which is
into the model
very high,
performance or the
but it's
milk
just to see how
exposure
much
for the
changes
different drugs.
you will
Here
see
we
for
have
the milk
shown
exposure
like
with the
4
different
drugs,
pH, and it might
acetaminophen,
affect your
digoxin,
overall
alprazolam, and caffeine.
the
And you can
prediction
see
for
the drug
the milk
exposure
to
in
plasma
plasma
ratio,
and
and
you
the
can
milk
see
on the
here
right
the
hand
effect
side
of
for
all
all
these
these
drugs.
and
we
the
also
lower milk
looked
exposure
into the
was observed
different
with the higher
parameters
pH,
provided for the
which
milk,
might
and
be the
mainly
case
milk to plasma
in the
ratio.
real life as
And
well,
as you can
where
see,
you
given
see
here
the higher
the
lower
observed
exposure
and the
in the
predicted
colostrum
milk
due
to
to the high
plasma
pH,
ratio,
and
the model could
maybe the
predict
higher exposure than the
the
colostrum in mature milk
provided
pH
the
due to
clinical
the change in the milk
plasma
pH
ratio
later on
with
the lactation model.
so that
here.
overall shows that
And all the
the
profiles
milk
were
pH
also
is more sensitive to
predicted
the
well to the prediction of the milk to
so
plasma
that
ratio
was
and
with
can
the
change the
Frischker model,
overall
and we also
milk
looked into some
exposure.
of the compound and
Also
looking into the effect of phenotype,
the milk exposure
so this is
utilizing
the
the log
example
transform
for
model.
the tramadol.
So here you can see, for example,
we also looked into
paroxetine
for the different phenotype as provided
and
here. So we
fluoxetine,
replicated the same
looking
clinical
into
scenario
the plasma
here,
and the
and
milk
we could
exposure.
first see the
Also
whether the
looking
milk
into
exposure
the
is
overall
predicted
milk to
well,
plasma
as you can
ratio,
see from where we also
comparison of the milk
took
to
into
plasma ratio
account
here as well.
while the
The
EM
different
data was
phenotypic
provided
typings
here
given
for the clinical
for this
study,
drug. So we
there was no
provided that
particular
poor
phenotype for the
metabolizer
different
data were
study,
available,
but we looked into
or the
the
clinical
effect,
data
how
that
it might
provided here
affect, and
between
overall
the
model
extensive
could predict
metabolizer and the poor
the milk
metabolizer.
exposure
And
well
you can see
with this
this model as well.
overall drug
And
effect
also
here
the
that
MP ratios were
you see
close to the predicted
higher exposure
close to
in
the
the poor
observed one.
metabolizer
For the milk side
looking
as well.
into the infant daily dose
Looking
or
into
the
the
relative infant daily
different
dose, we also predicted predictions
the
here. You'll see
the infant
that
daily
you'll
dose
see the around
quite
higher
well, and the prediction
like
versus
1.2-fold
observed
increase
ratio were
in the
within
overall
0.6 to
tramadol milk
1.7-fold in all
exposure
these cases
in
for the
the
different
PM
studies
mothers, and that is also
that we
reflected
performed
in
here.
overall the relative infant dose calculated on the PM, so which is on the higher side for the PM due to the
effect of
higher
change
exposure
in the milk
in
pH.
the
But
PM
first look
subjects.
into here
And similarly,
about the performance
also if you
of the
look into the
fluoxetine
pH effect,
so as I
here
said,
we
will
also
also
have
see the
the option
changes in
to
drastic changes in the
look
milk
into
to plasma
the
ratio, considering
metabolite
these changes in the milk
exposure
pH
as well in the milk.
So this is
While
the
we
performance
saw
showing
there
the
are
parent
changes
drug in the plasma,
happening
which you already
and
seen the last
drug
example.
to
So
the
you have the
milk
metabolite
pH,
exposure as well
when you're predicting
in the
milk
plasma and in the milk to plasma ratio.
there are also other
When we talk
parameters
about
that might
the
affect
relative infant
the
dose,
overall
it's important to take
predictions
into account
for the milk
also
to
the
plasma ratio,
metabolite
like the
infant
fat
dose as well.
content.
When we are
And this is
looking
just a
into
preliminary
predicting
analysis that
how much the drug will
we
be
started
ingested
doing
by the
to see the
infant.
effect
So
of
here we
different
also
milk
looked into the
parameter
different
relative
to the
infant
prediction
dose
of the milk to
as you
plasma
can see for
ratio.
the
So
parent
this
and
just
the
follows the
metabolite
default model,
and the
and
overall
we might have to see the different
parent
model how
and
it
metabolite
predicts
dose
for the different
combined.
models.
The
So
total
utilizing the
relative
different
infant
set
dose
of compounds
was predicted closely to what
you
was
can see
observed
that
clinically.
having the different change in the different
Looking into
fat
the
composition or
sensitivity
change in
to
the
the milk
pH, it can
we
affect
took
the
this
overall
example and
the
also
milk to
looked into
plasma
the
ratio predictions as well.
sensitivity
So while we know that whether changes in the milk pH, because there are changes in the milk pH happening dynamically from the colostrum, which is the early milk, to the mature model in the next. So you see the changes in the milk pH that might also affect the overall milk to plasma ratio. All the dynamic utilizing the sensitivity analysis taken into account within the model to allow you to incorporate pH or see the changes with these, considering the different milk pH from milk pH 6 to so 8, that which the dynamic lactation very high model, but it's just to see how much changes you will see for the milk exposure with the different pH. We looked into the pregnancy and lactation model and overall capabilities in the prediction for the milk to plasma ratio, and you can see here the effect of milk pH that in the perinatal PBPK lower model application was so this is one of the example with the higher pH, which might be the case in the real life as well, where you see the theophylline, which is lower exposure in the colostrum due to the high pH, to see the drug maybe the higher exposure than the colostrum in mature milk pH during the change in the milk pH later on in the umbilical cord, so that overall pregnancy that as well as in the breastfeeding pH is. So what we did here, we first to the prediction of the milk to plasma ratio data in the non-pregnant women, overall milk exposure, developed the model in non-pregnant women, also looking into the prediction in the pregnancy model, PPK model, also looked into the drug level in the breastfeeding mothers with the lactation PBPK model for the different phenotype by getting the here, so we replicated the same clinical scenario here, and we could from the lactation model we incorporated this infant daily dose as you can to the neonatal PBPK model to see how much exposure to plasma ratio here as well, particular dose. While the EM data was provided here for the for this drug, there was also being metabolized to caffeine. For metabolizer data available, but we looked into the effect how it might affect. We also between the extensive metabolizer and poor metabolizer as a metabolite, and overall drug effect here that the caffeine formation here, which we'll look into higher the other side as well. And the model also provided some information from the looking into the predictions that we had. Predictions here will also look into the detail in the next version. So these different model that is also available in the Simcyp, they are all combined to look into in the PM mothers, and that is also reflected in overall the perinatal relative infant dose calculated on the PM, so which is on the higher side for the PM. Okay, so this is for the in pregnancy PBPK model. I'm not showing the non-pregnant and similarly developed and verified in the non-pregnant to the pH effect PBPK model, also see the changes in look into the pregnancy PBPK side of things ratio, considering these changes in the milk pH. Here you are seeing the dynamic while changes. We saw there are contribution of the different elimination pathways to the overall clearance of the theophylline pH when you're predicting, as you can see here, milk to plasma ratio. There are also other parameters that the overall FM for the different predictions, enzyme pathways like 1 like the fat content, and this is just a preliminary analysis side. And as you know that to see the effect of decrease in the overall A1A2 to the prediction activity in the pregnancy ratio. So this just follows the default model shown here with these. We might have to see the different model how it predicts for the different models. So this utilizing the different set of compounds provided from the compounds, you can see that from the output in the simulator, different change in the different fat composition or change in the pH, it can affect the overall of the milk to plasma ratio, the theophylline as well. For the different maternal concentration, we know that at a different gestational week, so the first trimester, second trimester, third trimester, and the fourth trimester. So model could capture these data as well in the next version also, of the simulator, where you'll be provided with the model all the dynamic different umbilical concentration and the concentration provided at delivery, allow the data were very sparse or see the changes. We included different studies to look into the model performance for the so that the dynamic lactation in the umbilical cord will in the next version of the simulator and at delivery as well. Okay, so we looked into utilizing the lactation model and model capabilities provided here. Let's have a look into overall the performance was utilized in the maternal side of things. PBPK. Now looking into the neonatal PBPK. So this is one of the example. So as I said in the preterm, the theophylline is the pharmacokinetic of the caffeine. Theophylline, which is the additional drug here in the preterm, which is so what we did is that drug prediction of the drug PK before we built a model during with this caffeine the prediction in the umbilical cord or after pregnancy, as well as in the breastfeeding.
The FMs are
so what we did here, we first
you see the
preterm gestational week, so the data in the non-pregnant women
to 40.
And here the model in non-pregnant
postnatal
women
age, which
looked
is
into the prediction in the pregnancy
model
age, like 0 to 14 days here.
Also looked into
and you can see
drug
the
level
in the
pathways
breastfeeding mothers
to
with the
overall
lactation
clearance
PBPK model
here
in the
by
for the
getting
theophylline in the preterm
infant daily dose that would be
babies
ingested by the
infant.
so in the
From the
preterm model,
lactation
we already
we
have
incorporated this
the
infant daily dose
CYP1A2,
to the neonatal
CYP3A4,
PBPK model to see how much
and we
exposure
also
you will see
consider the
by that
CYP2E1
particular
enzyme
dose.
as it is also involved
While
for the theophylline.
this drug,
And due to the
availability,
its
non-availability of the data in the
is also
preterm
being
infant, we
metabolized
use
to
the
caffeine
same
here
level
converted
as
to
in the
caffeine
full
here in
term
the
infant,
neonatal,
which is
and
absent
you can
in
see
the
the changes.
adult.
We
In
also
these
looked into the
different
caffeine side as
FM
well
as a metabolite, and we
was
also
seen
predicted
due to
the
changes
caffeine
in the
formation here, which
maturation
we'll look into
due to
the
born
other
in
side
the
as well.
different
Preterm
and
age,
the
so
model
you'll
also
see the
provided
overall
some
changes in
information
the
from the pregnancy
the overall
model
FM for the
predictions that
different
we had.
enzymes. And we will
So
also
we
look into
developed
the detail in the next version. So this different model that is also available in the Simcyp,
data that
they are all
combined
to
to build
look
the
into
model
a drug
for
to
the
see how it
theophylline
will
and its
perform at a
conversion to
different
the
scenario in the
caffeine. So basically, the substrate
perinatal
metabolite PBPK
side
model
of
was
things.
developed in the neonate.
Okay,
Showing
so
the
this is for the
showing the
pregnancy
model building
PBPK
here.
model. I'm not showing the
And
non-pregnant.
this was
So model was
further
first developed and verified in the
utilizing
non-pregnant.
the
Several
PBPK
model
clinical
and
studies
then
given
looked into
in
the pregnancy PBPK side of things.
preterm neonates.
So
At different gestational week, as you
here
can
you are
see,
seeing the
different
dynamic
gestational week
changes
studies
in
has been
the
incorporated
contribution of the different
to
elimination
verify this
pathways
model
to the
to see
overall
how the
clearance of the
prediction works
theophylline for the overall neonatal PBPK model.
As you can see
and as
here,
you can see for the different
the zero
theophylline
gestational
concentration,
week, you can see
and also
the
some of
the
overall FM
studies
for the different
showing the
conversion of
enzyme
the
pathways like
to
1A2
caffeine.
the caffeine
1A2
formation
to
was
E1
captured well
mainly
in the
and the
model.
renal side.
So that
And
that
as
gives the
you know
confidence
that
the
you see the decrease in the
is
overall
predicting
A
the concentration well
enzyme
that can
activity in the
be
pregnancy. You can
utilized
see
to
these
see
changes,
the
the overall drug
shown
exposure
here
when
with
we
these
look
changes
into
in the FM at different
the,
gestational week.
so the
This
drug ingested by
information
the
can also
breastfeeding
be
women to see how the
provided
exposure will look like
from the
in these
output in the
neonates.
simulator.
So that was about developing the
Here
neonatal model
you
and
see
seeing its verification.
here you see
Now
the
overall performance
coming into
of
the lactation model. So as you can
the
see here,
theophylline for the different
this is the model
maternal
performance
concentration
in the
at
breastfeeding
a different
mother. So
gestational
again,
week. So the
additional
first trimester, second
studies
trimester,
were
third trimester
taken into
and the
account
fourth
to see
trimester.
the
So
overall
model could
model
capture
performance
the
and how the
these
milk
data as
exposure
well.
is predicted with the
Also
lactation model, and you
looking
can see
into
the
fetal
exposure
side of
in the
things,
plasma
with different study, and
model
similarly
predicted
for the milk.
different umbilical concentration
Utilizing
and the concentration
information
provided
that we
at
got from
delivery,
the
although the data
lactation
were
model,
very sparse.
daily infant dose,
We included different studies
this
to
dose
look
was
into
considered,
the model
and it was
performance
divided
for the
prediction
into
of the drug
6
concentration in the
dose,
umbilical cord and in
giving into
amniotic
account
fluid
the
and
same
delivery as well.
to resemble the
So
4-hour frequency pattern
utilizing
for
the
the
different
breastfeeding
after the
as
birth.
provided here.
So
So
you
you get the total
show overall the performance was predicted
infant
well
daily dose
in
as
the
mg per
maternal
kg per
side
day.
of
So it
things.
was
Now looking
divided
into the
into the
neonatal
mg per
PBPK
side of things.
per hour to
So as I said, in
to
the
resemble the
preterm,
breastfeeding,
the theophylline is
as the breastfeeding will
converted to the
will
caffeine,
happen,
which is
the
the
drug will
additional
go to
pathway in the preterm.
the
So what we
babies.
did is that we
So this
shows the
set up a
performance
model, or we
utilizing
built
the
a model
dose
in the
taken
neonate
from
with this
the
lactation
pathways
model.
assigned.
So
So you can see here,
this is for the
similarly, the
preterm
FMs are
population. Again,
provided
as I
here.
said, all
So you
the
see the
preterm
ontogenies for the
gestational week.
enzymes
So
are
the preterm
considered
born at
here.
25
And also
to
we are
40,
taking into
and
account
here
the
you see
time
the
varying
postnatal
physiology
age,
here,
which is their
which
the
takes into
biological
account
age, like 0 to 14 days
dynamic
here.
changes in the
And you can see
physiology
the
for
different
the
whole
pathways
simulation duration,
contributing to
and
the
just to
overall
note
clearance.
here in
On the x-axis
for the theophylline in the preterm
the data you see
babies
is
for the days,
so in the
not the
preterm
hours.
model we already
So it is
have the ontogenies
simulated
defined
for
for
the
CYP1A2,
14 days.
CYP3A4.
And you see the
And we
performance
also
here.
consider the
So
CYP2E1
just to
enzyme as
explain
it is
a bit
also involved for the
about this
theophylline.
color combination,
And due
so
to
you
the
understand well, is this is the
non-availability of the
theophylline
data in
concentration.
the
So you have
preterm
been
infant, we
and
use the same
95th level,
and then
as
there is
in
a
the
caffeine
full-term
formation.
infant.
So
And you
theophylline
can
is
see the
given,
changes
caffeine is
in
formed,
these
which is
predicted
FM,
by the model
was so this first graph that you
was
see
seen due to the
for
the
the
changes in the
for a
maturation
therapeutic dose. So
due
just
to
to
born
see
in the
at
different
therapeutic
preterm
dose that
age.
is
So
given
you'll
to the
see the
preterm
overall changes
infant
in the
for
the
a
overall
neonatal
FM for the
apnea,
different
which
enzymes.
it was used used to treat this condition.
is provided here, and you also see the data prediction at different gestational weeks. To build the model preterm who are born for the theophylline at 28 gestational, 32 gestational week, or 38. So basically, the substrate this is at birth. PBPK model was developed in the neonate. At different preterm showing infant, you can see this exposure for the theophylline and the formation of caffeine. And this was further verified utilizing the several clinical studies given in the from the lactation model. Preterm the data was provided at different gestational week, and you'll also see that different gestational what we did here is that incorporated to verify this model in the cord at birth was included for the baseline neonatal PBPK model to mimic the clinical situation, because this is at birth, and you'll see and also some of the studies present in the neonate. So this was of the included as a baseline caffeine. The caffeine formation was captured cord level in the model at the so initial concentration. That gives the confidence that the neonatal model is predicting the concentration that you see that can be utilizing the C average to see the and what one is overall drug exposure the milk Cmax method, so that both gives the different infant daily dose. So just to look into the different scenario, how that will look like when you use neonates. So that was about developing the neonatal method and seeing this verification. Utilized for calculating the infant daily lactation model. So as you can see, so here, what you can see here is this is the model performance. First, you in the breastfeeding mother. Overall, so again, additional studies where you can say so the therapeutic window is also provided here model performance and how the so you can say exposure is predicted in this lactation model, and you can see the caffeine exposure in the plasma with different study, and as you can see, some of the concentration is within the therapeutic window. Utilizing so it the might information that we got like the therapeutic effect in this case, daily infant maybe not in that case. Was, and you also see the changes in the overall. It was divided the clearance of the into as there are different gestational keeping into account the preterm involved here due to the maturation of the enzyme, because with the 38 gestational week there are some enzymes so you get the total be mature at that time. Infant daily dose as mg per kg per day, so it was divided into the mg per kg per hour. Caffeine formation was less. Like so this gives the overall idea and how you see the changes with the different will happen. Preterm infants will go to the born at the different gestational week babies. But also so this shows the performance the dose that is ingested by this preterm infant, the lactation model exposure here. So looking into this is for the preterm population again, as I said, all the caffeine formation for the enzymes that have been done here. It is very low time varying physiology also here. The theophylline concentration is very low, and it might dynamic changes in the physiology for it might the be at the level that duration. It may not and contribute. Just to note here the on the x-axis it may not data you see is it's very low to days any not the hours effect. So it is so similarly simulated for the scenarios 14 days can be the different scenarios the performance can be simulated to see so how you see the drug exposure about this color combination, so you understand well is this is the this one is the another example just to see whether if you not include and then there's a level as a baseline so to see the different scenario. Caffeine so this is just which is while we are not recommended model we are just utilizing so this first information and utilizing the overall model capabilities that we have within the simulator. So just to see the different scenarios that is given to the preterm for a single drug you can see for a neonatal before after during the pregnancy to treat and in the breastfeeding condition or in the is provided here, how it will and you also behave see the what exposure at different gestational weeks. So for the preterm who are born the overall example 28 gestational 32 gestational week or similarly another case this for the utilizing the same approach for the non-pregnant you can see these exposure for the theophylline and the formation of neonatal. So the same approach as I and then utilizing the milk is shown here and utilizing the apply the similar approach for the lactation model as well. The data was another example for this and you'll also see that similar approach was provided here to see the drug concentration throughout concentration in the cord at birth was stages as a baseline maternal or fetal to mimic the clinical situation because this is at birth and you see some concentration already present. So just to summarize, this was as you can see included as a baseline to provide the cord level at the initial concentration. You can see the different concentration at the different tissues. There are two
You can also look into the overall drug ingested by the breastfeeding and one is utilizing the lactation model.
So that
Also with the model flexibility as I
infant
shown
daily
for
dose.
some
So
of the
just to
example, the
look
phenotypic
into
or
the
the
different
ethnicity
scenario, how that will
can also be
look like
defined
when
and
you
utilized
utilizing
within the
different
model. So
method
overall, the model can be
utilized for
used to
calculating the
provide
infant
the
daily dose.
insights for when the clinical data is limited. Specifically, it's not always possible to see on the fetal side or maybe that different gestational side
graph.
or you can also
you
look
can
into some
say,
of
so
the
the
dose
therapeutic window is
recommendation
also
and
provided
see
here
the
with
dose
the red
adjustment based on the
baseline. So you can
exposure.
say
In this case,
the caffeine
as we also seen
formation
in some of the
might
case
be,
example,
as you can see, some of the
if not
concentration
that,
is within the therapeutic window.
there are
So
different
it might
options
give
that you can
like the
also
therapeutic effect in this
to,
case, but
answer some of
maybe
the
not
what
in
if
that in
questions
that case.
overall.
And you also see the changes
It can
in
be
the
utilized
overall
in a
the
different
clearance of the
way.
theophylline
While
there
there is
are
a
different gestational
confidence in this model and we have provided
weak preterm involved here.
similar case
Due to the
studies as well.
maturation of the enzyme, because
we are
the 38
continuously
gestational
expanding
week,
the
there are
model
some
and
enzymes that might be
verifying
be mature at that
based
time
on the data
than the
availability
28
that we have with
gestational week,
this.
and you'll see more clearance
Okay, so with
of
that,
the theophylline, and the caffeine formation was less.
and
So this gives
like
the overall
acknowledge
idea on
the
how
Simcyp
you see the
Pregnancy
changes with the
team that we
different
have.
preterm infants
And
born at the
happy
different
to
gestational
have any
week,
questions.
but also looking into the dose that is ingested
Thanks,
by this
Amita.
preterm infant, how you'll see the
If anyone
exposure
wants
here.
to
So looking into these
raise their
6
hand, they
graph,
can
whether
ask any
it's C average
questions.
or the C milk, it looks like the caffeine formation that has been done. It is very low.
Certainly in
Also, the theophylline concentration is very low, and it might.
Can you unmute yourself, or do I need
it might be at the level that it may not contribute.
Yeah, thank you. That's a great presentation. Very helpful. Maybe you
it may
can
not,
comment
on
it's
very low to
substrates
exert
of
any pharmacological
PGP
effect.
and BCRP,
So similarly,
and how does the
these
model handle
scenarios
the
can be,
fetal
the
placental
different scenarios
barrier
can
as well
be
as the breast
simulated
blood
to see
barrier,
how you'll see the drug
how
exposure
accurate those
in these
predictions are at
different
this point.
preterm infants. This one is the another
So you're
example,
talking
just to
about
see whether if
the
you not
drug
include the cord level as a baseline to see the different scenario.
So this is just
PGP and BCRP,
while we are not recommended
like,
anything, we are
BCRP
just utilizing the
substrates
different
tend to
information and
excrete quite a bit in the
utilizing the
milk.
overall
So I was
model
just wondering
capabilities that
how
we
the
have
model
within the
handle
simulator
those and
to see the different
have you
scenarios, and you
look
can
at
see
those
that
and the accuracy
for a
of the
single drug, you
predictions.
can see that different pictures
we have not
before,
looked into
after,
like as
during,
such the PGP
the
or the
pregnancy,
BCRP substrate,
and
but
in the breastfeeding
we
mother
have the
or in
option to
the
provide
preterm neonates,
these
that how it
transporter
will behave
kinetics
or what exposure
for the
you can
maternal
expect
side or
in this
as well
model.
as
So this is
for
the overall
fetal
example
side.
utilizing these cases.
While there's
Similarly,
not enough information
another
or maybe
case for
there's
the
a difficulty to
utilizing the
have
same approach for the
a proper
non-pregnant,
PGP
pregnant,
substrate to derive the
lactating women,
ontogeny.
and also looking
hurdle
into the
to
neonatal. So the same approach
the
as I
ontogeny
explained
for the theophylline is
so we do not have the
shown
ontogeny
here as
and you
of
can
now
apply the similar approach
regarding
for
the
the
PGP
other drug as well.
BCRP.
Another
you
example
can
for the
definitely
ceftriaxone,
incorporate it.
similar approach was provided to see the drug concentration
We do not
throughout
have at the moment any
a different
example showing
the
stages,
or maybe I'm not aware
maternal or
of
fetal
the
side in
drug
the
that
lactating
we
mother and
looked
also
into
for the PGP or the
looking into the
BCRP
neonatal
specifically.
side of things.
Great, thank
So
you.
just to summarize, as you can see, with the model capabilities providing all the options, you can see the different concentration and the different tissues. You can also look into the overall drug ingested by the breastfeeding, in effect, utilizing the lactation model.
Yeah, I have one. So
also with the model
what are the
flexibility, as I shown for some of the example, the phenotypic or the ethnicity can also be defined and utilized
Is it simply physical
within the
chemical?
model. So overall, the model
Have
can
views,
be used to provide the
physical
insights for when
chemistry
the
in
clinical
general,
data is
and
limited.
no transporters
Specifically,
at this point,
it's not
sounds
always
like.
possible to see on the
Yeah, so
fetal
as I said,
side
there
or
are
maybe
two
that
model
different
options.
gestational side.
In terms
You
of the
can also look into
physiology,
some
we
of
have
the
all
dose
the
recommendation
and
see
the dose
physiology
adjustment
defined
based
there,
on the exposure,
utilizing the composition for the breast
so
tissue and the
as
all
we
the milk
also seen in
parameter
some of the
as I
case
explained, the milk
example,
pH, milk fat,
if not that,
milk volume that has been
there are
utilized in
different
the model.
options that you can also
So depending on the model
simulate
assumptions,
to,
so because
answer
there is
some of
really
the
limited
what-if
information
questions.
on
Overall,
the transporter side of
it
things
can be utilized
on
in
the
a
breast and milk
different
barrier.
way.
We do not have
While
much information
there is
on
a
the the changes
confidence
in
in
the
this model,
transporter
and we
or
have provided
what transporter might be present.
similar
There are
case studies as well.
information we are continuously there, but it does not really gives a clear picture
based on the data
but we have a
availability
generic
that we have
transporter
with this.
provided here, so that can
Okay,
be taken
so
into
with
account.
that, and my
within
presentation,
these options
and I
provided
would
for
like to
the flux
acknowledge
or the
Simcyp
uptake
Pregnancy
transporter
and
that we
lactation
have
team
already
that we
included
have.
in the permeability lactation model, so that
And
can be
happy
incorporated.
to have any questions.
In many cases, I haven't come across any data
Thanks,
that
Amita.
shows these kind of experiment or
wants
the
to,
data to utilize it in the
raise their
model.
hand, they can
But
ask
I
any
think there
questions.
are now experiments that are available that look into the PACY permeability within these
Certainly encompassed a lot of work.
these barriers to
Lydie,
see the utilizing the memory epithelial
unmute
cells, so that
yourself, or
can be
do I need to?
probably
Yeah, can you hear me
included
okay?
to provide the
Perfect,
PACY
yep.
permeability
Yeah,
and
thank
can
you.
be
That's a
utilized
great presentation,
to
very
see the
helpful.
predictions.
Maybe you can comment on substrates of
On the milk side,
PGP
yeah,
and
the
BCRP,
regarding
and
the
how
FU,
does
yes,
the model handle the
for the FU
fetal
milk,
placental barrier as
we
well
are
as the breast
currently
blood
utilizing
barrier?
the prediction
How
method
accurate
provided
those
by the
predictions are at
Atkinson
this
and Bag,
point?
and it's being utilized for both the models. So you're talking about the drug.
Are there any, sorry,
that are
I'm gonna
PGP
keep
substrate in the
asking
pregnancy?
questions.
Yeah, PGP and BCRP.
Have there been
I know
any
BCRP
regulatory
substrates
examples
tend to
where
excrete quite
a
a bit in
question
the
has been
milk.
asked,
So
hey,
I was wondering
does your
how the
drug get
model
into
handle
breast
those
milk?
and
And
looked
someone
at
has
those and the
used the
accuracy of the
modeling to
predictions.
answer that question, and has that been
We have not
accepted?
looked into like as such the PGP or the
I think
BCRP substrate, but we have the option to provide these
and we are
transporter
trying to
kinetics
provide in the models.
for the maternal side,
unfortunately,
or
we do
as
not
well
have
as
any
for the fetal side.
any example as of now.
While
And
there's
it's relatively
not
new that
enough
we have added
information,
in
or
the
maybe there's a
simulator.
difficulty to
But
have
yeah, I think
a proper PGP
there are different
substrate to
groups
derive
that
the
I
ontogeny.
know are using
That
the
was a
model,
hurdle
but not as of
to
now
looked
in
into the
regulatory
ontogeny,
submissions.
and
but yeah,
so we
that
do
would be
not
our
have the
target.
ontogeny as of now, and
Yeah, thank
regarding the PGP BCRP, but yeah,
Lai,
we
I
can
think you've
definitely
got another
incorporate
question
it.
to
I have another question. Yeah, thank you.
We do not have at the moment
because the
any example
transporters are
showing
not
the
implemented in
or
this
maybe
model.
I'm not aware of
in your
the
2D6
drug
example
that we
for the
looked into
EM
for
and
the
the
PGP or the
PM,
BCRP specifically.
why would the milk to plasma
Thank you.
ratio be different? I mean, I can understand your plasma concentration will be higher, but if it's just passive, you will have similar milk to plasma ratio. Why would the
Any
ratio
other
change?
questions?
Because the
or
exposure
comments?
is changing.
Yeah, but your
So-
milk exposure also change, right?
Yeah, so this is the milk exposure.
Yeah, I have one. So what
Yeah,
are the
so
main
why would the ratio
input
change if
parameters?
there's no change?
No, there's no
Um,
change in the ratio.
in determining
there's no change in the
ratio is the
drug
same,
milk
yeah.
concentration?
It's just the
Is it
infant
simply
dose.
physical
okay.
chemical?
You have the exposure high because it's coming from the plasma, so your ratio is same. But overall exposure is high in both the cases, plasma and
no
milk.
transporters at this
So when
point,
you're looking
sounds
into
like.
the milk side and looking into the
so as I said,
dose,
there are two
there is
model
more
option
drug going into the milk. And
you
in
see
terms
the
of the
higher
physiology, we have
for
all
the
the
infant.
breast and
Okay,
milk
great.
physiology
Yeah,
defined there,
I thought I saw a
utilizing
place
the
that
composition
milk ratio
for the
changed.
breast
Yeah, great.
tissue
Thank you. That
and
makes sense.
all the milk
Thank you.
parameters as I explained, the milk pH, milk fat, milk volume that
Okay,
has been
any other
utilized in the
questions?
model. So depending on the model assumption, so because there's really limited information on the transporter side of things, on the breast and milk barrier.
Thank you, Amita.
We do not
That's
have
really
much
great
information on the
presentation and
the
really
changes in the
useful.
transporter or what transporter might be
People want to
present.
contact you.
There are some
you got your email
information
address,
provided there,
so,
but it does not
please
really
do.
gives a clear picture. But we
just
have a generic
on the final
transporter
point-
provided here,
Oh,
so
sorry,
that can
there's a
be
few
taken
more
into account
questions that suddenly popped up.
within
So,
these options provided
yeah.
for the flux
Did you
or
want
the
to take
uptake
that?
transporter that we have already included in the
Sure, can
permeability
you
lactation
read
model,
them?
so that
I
can be
can't really
incorporated.
access it.
In
Are they
many
in the
cases,
chat
I
box?
haven't
No,
come across any data that
Hello.
shows these
Yep.
kind of experiment or the
Sorry,
data
I
to
just
utilize
had
it in
a
the
quick
model.
question.
But I think there are
So in the
now
permeability
experiments that
limited
are
placental
available
model,
that
are
look
all
into the PACY
are all the
permeability within these
transporters incorporated in Simcyp, or
these barriers to see
is it still a work
utilizing
in
the memory
progress?
epithelial cells, so that can be probably included to provide the PACY
so
permeability and can be
you're talking
utilized
about
to
the permeability
see
limited
the
placenta model, right? This one.
predictions. Yeah. Yeah. So
On the milk
on the
side,
fetal side,
regarding
you
the
have
FU,
the option to include all
for
the
the FU
transporters.
milk.
Similarly,
We
the
are
placental
currently
kinetics, the
utilizing
problem is
the
just the data is not
prediction
enough
method
to
provided by
describe
the
these
Atkinson
kinetics,
and it's been
which we try
utilized
to
for
also
both the
look
models.
into and see. There are some data available
any,
that
sorry, I'm gonna
that
keep
looked into the
asking
the
questions.
changes in the overall
Have there been
transporter
any
level
regulatory
at different
examples
trimesters.
where a question has
From
been asked,
I think
hey,
there's one
does your
from a
drug
group,
get into breast
and
milk?
we looked into that, but there's
And
not
someone
enough
has
data
used the
for us
modeling
to
answer that question,
utilize and
has that been
provide
accepted?
proper ontogeny function. So we'll be looking into some more data to come to utilize to derive ontogeny and provide it in the simulator. But for now, we already have an option for you to
example as of
incorporate
now,
the
and it's
ontogeny if you
relatively
want
new
to.
that we have
So you
added
can
in
also
the
incorporate the
simulator.
transporter kinetics
But
on
yeah,
the
I think
transporter side,
there are
but you can
different
also
groups that
incorporate the
I know
ontogeny.
are
So we
using
have
the
the
model,
option to
but
provide
not
the
as of
ontogeny.
now in
Hopefully, if the data
regulatory
is sufficient to
submissions.
provide the ontogeny,
But
we'll
yeah,
add
that
them
would
in
be
the
our
future.
target.
But there is an option at the moment,
Yeah,
but the
you.
ontogenies are not available so far.
Lai, I think you've got another question.
Yeah,
Right.
I have another question. Yeah, thank you.
But yes,
because
you
the
have all the
transporters are
transporter
now
given here, so you
implemented in this
can
model,
utilize them.
in your 2D6 example for the EM and the PM, why would the milk to plasma ratio be different? I mean, I can understand your
Any other
plasma
questions?
concentration
Any
will be
other question?
higher, but if it's just passive, you will have similar milk to plasma ratio. Why would the ratio
Feel like an
change?
auctioneer now.
Because
Final
the
chance.
exposure is changing.
Yeah,
Right.
but your milk
So
exposure
think,
also change, right?
Thanks
yeah,
again,
so
Amita.
this is the milk exposure.
Just one more thing before
Yeah,
you,
so
you go.
why would the ratio change if there's no
Kunal,
transport?
No,
on
there's
behalf
no
of the
change in the
IQ
ratio.
PBPK induction team,
there's no
is
change
going
in
to
the
be
ratio.
giving a
Okay.
talk
I
It's
see.
just
in
the
a couple of
infant
weeks'
dose
time, so
because
on
you have
Thursday,
the
the
exposure high
20th of
because
October.
it's coming from
and
the
it's
plasma, so your
looking
ratio is
at
same.
one of
But
the
overall
Okay, great.
exposure is high in
publications and
both the
outcomes
cases,
from
plasma
that
and milk.
publication in
So when
terms
you're
of
looking
current
into the milk
practices,
side and looking
gap
into the infant
analysis,
dose,
and
there
proposed
is more drug
workflows with
going into the
PBPK
milk, and you
modeling
see the higher
of
dose
cytochrome
for the infant.
P450 induction.
Okay, great.
Um,
Yeah, I thought I saw a
as you'll be
place
aware,
that the milk ratio
we
changed.
register for
Yeah,
the
great. Thank you.
members
That
area,
makes
so
sense.
please join
Thank
us
you.
then. I'll close this session now. Thanks again for everyone for joining.
Any other
and,
questions?
Speak to you soon. Take care.
Thank you everyone for attending.
Bye.
Thanks.
Thanks.
I can't
Bye.
see any more. Thank you, Amita. That's a really great presentation and really useful. If people want to contact you, you got your email address provided.
Yes.
So please do. Just on the final point. Oh, sorry. There's a few more questions that suddenly popped up. So
okay.
Yeah. Did you want to take them?
Sure. Can you read them? I can't really access it. Are they in the chat box?
No.
Hello.
Yep.
Yeah, sorry, I just had a quick question. So in the permeability limited placental model, are all the transporters incorporated in Simcyp, or is it still a work in progress?
Okay, so you're talking about the permeability limited placenta model, right? This one. Yeah. So on the fetal side, you have the option to include all the transporters. Similarly, the placental kinetics, the problem is just the data is not enough to describe these kinetics, which we try to also look into and see. There are some data available that looked into the the changes in the overall transporter level at different trimesters. From I think there's one from a group, and we looked into that, but there's not enough data for us to utilize and provide proper ontogeny function. So we'll be looking into some more data to come to utilize to derive ontogeny and provide it in the simulator. But for now, we already have an option for you to incorporate the ontogeny if you want to. So you can also incorporate the transporter kinetics on the transporter side, but you can also incorporate the ontogeny. So we have the option to provide the ontogeny. Hopefully, if the data is sufficient to provide the ontogeny, we'll add them in the future. But there is an option at the moment, but the ontogenies are not available so far.
But yes, you have all the transporter given here, so you can utilize them.
Okay.
Any other questions?
Any other question? Feel like an auctioneer now. Final chance. Right. I think thanks again, Amita. Just one more thing before you go. Kunal, on behalf of the IQ PBPK induction team, is going to be giving a talk in a couple of weeks' time, so on Thursday, the 20th of October. And it's looking at one of the recent publications and outcomes from that publication in terms of current practices, gap analysis, and proposed workflows for PBPK modeling of cytochrome P450 induction. As you'll be aware, we register for those on the members area, so please join us then. I'll close this session now. Thanks again for everyone for joining, and speak to you soon. Take care.
Thank you everyone for attending.
Bye.
Thanks.
Thanks. Bye.